costs a little bit more money, but obviously we can't ever let that be the barrier to us doing what needs to be done to care for people who are suffering from the most serious mental illness and addictions. The new contracts that are going out broadly to both expand the network further, but also create the network type behavior that I'm describing, will be, God willing, completed in July. You can imagine how much COVID has, kneecapped us and everybody for so many reasons. Anyway, I hadn't planned on talking about that. I just took 5 minutes, but it's a little bit of an update, and I think it's really important. I have a number of things that I'd like to talk about, and then I'll try to get through them quickly, and then I'm happy to take questions. I have up to an hour. At 5 o'clock, I'll get on another call, and I'm really glad that Connie's here with me, and I am very lucky to have Connie on my team. We're really, I think, pushing things in a direction that is long overdue and quite progressive. To start, I just want to frame out the idea of LPS in a broader sense and say that, we all know that individuals who are suffering from severe illnesses require, they need access to treatment. One of the challenges in the mental health field is that many people that are suffering do not want treatment. You all as family members know that as well as or better than anybody. So in order to get someone access to treatment when they don't want to have treatment, you have to think about ways to engage that individual. And LPS law and conservatorship is actually not in and of itself treatment, it's engagement. And I want to flesh that out a little bit to you. What I'm saying is that we have to figure out for people who are suffering and need treatment ways to engage them. And I look at engagement as a continuum. And just like you have a continuum of care, you have a continuum of engagement, an engagement continuum. And I call the tools for engagement the tools of engagement. And what I would say to you is that in every case, no matter what, when someone is really severely ill and is needing treatment, we have to be relentless about voluntary treatment, voluntary care, engaging them by bringing to them that relentless heart-forward effort that we talk about and that we aspire to, which includes having resources. And if you can think about voluntary engagement as one end of the spectrum and LPS conservatorship at the other, there are other tools. And the other tools, as examples, one would be the advance directive, which is not something that exists in California, the psychiatric advance directive, which basically allows for somebody who has suffered from severe illness the opportunity to articulate what type of treatment they want when they're stable. These are the medications that I would like to take. These are the doctors or the doctor who I will work with. This is the hospital or the facilities that I will go to when I'm sick. And that becomes something that is actually documented and has legal ramifications, so that when someone is unstable and clinically that is attested to a court, the advance directive kicks in. That would be an example of a tool in the what I call a continuum that could be very helpful that does not exist. Obviously, AOT is another tool, and I would say that AOT, while I think it's great in principle and in practice in some cases, it needs to be reworked. It needs to have less exclusionary criteria. It needs to be less burdensome from an administrative perspective, and it needs to have, in those cases where it's critical, the power to Medicaid. And the reason that I'm bringing this up is we get very, very focused on conservatorship. We get very, very focused on grave disability. Now, I'm going to be talking about that with you, saying I want to shy away from it, but we have to be thinking about the context of disengaged people who are very, very ill, and how we go about engaging them. Because it's not a one size fits all, and it doesn't have to be all the way to frank paternalism. There are steps in that continuum. I hope that makes sense. I hope that makes sense. Actually, before I continue, maybe we ought to just, I want to make sure people. Gail, you're
Araceli, you'll have to answer that, but I don't think so. I think you've got a bucket of people. Am I correct? 77, Araceli?
Yes, right now we have 63 folks, and they've been here during the duration of the whole presentation. Yes.
Okay, that's great. I'm just going to try to get through this stuff, and I think about it, day and night, and I present about it and talk to so many people about it. So when I go through it, I feel like it's pretty straightforward, but sometimes it's not, and there's some stuff in here that's a new way of thinking, and I would just maybe ask that you be tolerant, and then at the end we can, when I finish it, as a part of the questions, I can try to clear anything up that hasn't been clear, or if there's disagreement or you think what I'm saying just simply doesn't make sense, which is completely fine, and I would want to know that.
Dr. Sharon, can I cut in just for a brief second?
Of course.
I'm Jim Farrell, and I'm out here in Orange County. I've been working with Gail for years, back and forth. In this meeting today, there is an LPS attorney from Orange County that is as passionate as you are on advanced directives. I would love to connect you two together. He's very passionate and want to do legislative work in this area.
I love that. I would say, Connie's here, but also we've got Gail. Gail is a portal for information, and I would ask that anything along those lines. We're open, obviously, to partnerships, and these are things that I'm certainly in my role trying to pursue through with my board and with other leaders at the state.
Thank you.
Okay. So the question really, at some level, if we just cut to the chase on applying the tools, really reflects back to LPS law and its original formulation, which was really based on living safely in the community. Because if someone cannot live safely in the community and they're unwilling to accept care and they're unable to live safely because of a profound mental illness, or I would say clearly an addiction, or both, we actually have a humanitarian responsibility to do something about that. And what we rely on right now, when it comes to certainly grave disabilities, food, clothing, and shelter. But what I would say is we really must take a step back and think about what does living safely in community mean? And we know in the acute sense, in the short run, in the imminent sense, what it means. And that, generally kind of reflects on dangerousness to self and dangerousness to others, and in terms of being homicidal or suicidal. And I would say we do a relatively good job with that. And it's consistent across jurisdictions throughout the state. But the question becomes, when it's not in the imminent sense and it's more chronic and based on patterns of behavior, we rely on these things, food, clothing, and shelter. And they are important, and they do reflect, they're indicators of the inability to live safely in community, but they're nowhere near all of the indicators. And some would argue that there probably are more objective indicators that we could use more effectively and that would be more reliable for frontline outreach workers, and also, frankly, the judges and the juries and the courts. So that's a big deal. And when it comes to thinking about grave disability, that's really where I go. And that's what I'm trying to argue and push for, is that can we look at grave disability as a larger phenomenon of not being able to live in community in a chronic way? And that if it is such, what does it mean to be dangerous to others in the chronic sense? And what does it mean to be dangerous to self in the chronic sense? And there's a lot of focus on the latter, dangerous to self, in terms of deteriorating physically and literally dying in the street because of lack of treatment. And the reason that I jump to talking about living safely in community, I think Connie may have mentioned it to you during her earlier presentation, is that I believe that that is really, in many cases, what ought to trigger our use of tools. We obviously, if someone's not living safely, we want to go and try to engage them with relentless efforts. But if that fails, then we actually are in a situation, because they're unsafe, of applying a tool. And we would apply the tool that seemed to be best indicated. And I would like to think that we can develop a set of tools that we would be able to use depending on objective indicators of what's going on with the person, and advance up that continuum, become more and more paternalistic as indicated based on that person and based the severity of their condition and their actual risk of obviously bad outcome. And then what I would say to that is that when you apply a tool at some level, you are restricting civil liberties, which is a big, big deal. And if you're going to restrict civil liberties, I would say you have no business doing it unless there are dedicated resources up front. When we do relentless engagement, it needs to be engagement that comes with resources guaranteed. And when I say resources guaranteed, I'm talking about a full, a real full service partnership. And we're in the process of re-engineering the way that we do all of our FSP. And we can talk about that. Guaranteed housing and a guaranteed bed, open or locked, and acute or subacute locked. If you have those available to you as resources, then you can use the tools. Now, that's a problem because we don't have enough resources in this space. But what it does for me is it allows me to do what I've been trying to do since I got here, and that is allocate and dedicate as much resource to those with the most profound mental illness, because I think that that's our core mission as a mental health department in the public space. It also pushes hard on the state to say to the state, look, if you're serious here about like ending homelessness and not incarcerating people with serious mental illness, put skin in the game like you have never done before, and actually realize parity. And parity is a big issue that we could talk about as well, because there is not parity. And if there were parity, we would, I believe that this department would go from a $3 billion to a $6 billion department. And I believe that all of the private insurers would actually do what they need to do when someone has a chronic severe illness that's not medical, that's related to a mental illness or addiction, and pony up the funds to help them. That does not happen, in spite of the fact that there's both federal and now state law with the passage of SB 855 this year, which we were very involved in. Now, with all that said, what I would like to talk about next, and I think this is the thing that Gail prompted, you're kind of requesting me to come in, is a pilot, the home pilot, our homeless outreach and mobile engagement pilot that Connie may have talked to you about a little bit, which really takes a lot of these principles and applies them using existing law. And when I say existing law, I'm basically talking about the use of grave disability in its current form. But the approach is quite different. We obviously have a lot of people who, in this pilot, a lot of people who are homeless, who are, profoundly ill, and more people, as we know, are literally dying in the streets. Not all because of having serious mental illness, but having serious mental illness is a big piece of it for a portion. And a lot of that kind of leads to lack of access to medical care, which we know. But what we're doing in this pilot is we're actually declaring that this department has core responsibility and will focus on homeless people who are the most vulnerable and that are suffering from the most severe illness. When I showed up, we really were a department that did outreach and engagement, but we did it in a general way, much like the other teams, whether it was through LASA, whether it was through the Department of Health and Housing for Health. Yeah, I can't tell you how many conversations and how many times I had to kind of go back, and we're still in the process of doing it for people in that culture to understand that we're a specialty plan, and then we have to do specialized outreach and engagement that leverages the skills that we have to go after people who require a level of expertise and take ownership of that. In fact, I think that's one of the biggest problems in the homeless arena is we take this approach that, oh, we're going to do all of these things and we're going to throw all this money. It needs to be very strategic. People have to take portions, take puzzle pieces that they go after, and that's what we're trying to do, and then be held accountable for that. Anyway, the pilot's framed around that let's just call it that population as it exists at any given time, recognizing that these individuals are literally at risk. They're not living safely in the community, and our outreach engagements are relentless and failing. So in other words, we're going to people and we're bringing what I call the home platter. And I went over the home platter with you before, 24/7 clinical care, or a dedicated team, guaranteed housing, and access to open and locked beds, and locked subacute and locked acute. And going to that and offering that and having that available for everyone that we're going to have in the pilot. What Connie may have mentioned is actually with that dedicated resource, and I think, frankly, the empowerment of our staff, we're finding that we're engaging people who have never been engaged and not been engaged before, which is incredible. That's the victory. If we're able to do that more and more and not rely all the time on having to use tools, that's a good thing. But when we get somebody, we're not able to engage them, we decide that based on the fact that they're not living safely in the community and that the resource array is not changing that dynamic, we then pursue outpatient conservatorship. And we do it literally in the street. And we are, I believe, finding a level of advocacy that we're very happy with. And Connie, I'm hoping during the Q&A we can kind of chime in, and I'm aware of certain cases. I know that you're aware of all of them, given your role. But what it looks like is that we actually then, after not engaging voluntarily, have conversations. And I've done this with patients. I actually go out about once a month. I'd like to go out every week. I haven't been able to and have patients and say, listen, you're not engaging with us. You are very sick. Just straightforward conversation. The resources we've been talking to you about are still available to you, but we're going to leverage existing law to compel treatment as a way to engage you. And then it gets filed. And then there's a number of processes that Connie knows better than probably anyone on the planet that we go through in order to basically advance the ball. Now, the importance of taking this approach, I think, certainly in my opinion, and this goes back, Gail, you may remember the standard of care motion from Catherine Barger, which I put together with her after being here 6 months. I know Connie does. There were a lot of recommendations that came out of it, is that we don't have to use the hospital to get a conservatorship in all cases. And I will say that there are many people who are traumatized by being hospitalized. In fact, many of the people that we're trying to engage, we can't engage because of their experience. And that's a big deal. If you don't have to use a hospital to engage someone and get them conservatorship for a chronic condition, that's a good thing. It's a good thing for them. It also obviously saves us money because we end up, when we're going to conserve someone, putting them into the hospital for, as you all would know, months and months and months at great expense. We're also gumming up a system. As I told you, we're 4,000 beds short. So we ought to not use beds that are there for acute care when we can avoid it. And then in addition, what we find is that when people do get hospitalized, and then let's say there's a Reese hearing, and then they get medicated, and they're getting access to, they basically are cleaned up over a period of months. Then when they come into court, what the judge will see and what a jury will see is someone that's actually gotten treatment for a few months. But that's not reflective of that person when they're not engaged and when they're, for example, in the street. And in fact, with our pilot, we're able to, with our clinicians and our doctors, tell the court what's going on with that person in real time. Not, oh, yes, they've been eating all of their meals, and oh, yes, they've been sleeping well, and oh, yes, they're compliant with their medications most of the time, and oh, there haven't been any behavioral outbursts. We're saying, listen, this person's literally not living safely in the community. They've got a profound mental illness. And we believe, because they're not engageable, that we ought to engage them as a part of their recovery by guaranteeing resources, including either a public or a private conservator. And if it's a public conservator, at a ratio that's manageable. And that also obviously is a part of that platter, the home platter, is having enough deputy public guardians to do the work. And I think that you can imagine that is going to change the kind of data that's landing on the judges in the judge's court, and will hopefully get a little bit more fidelity between the reality of a person when they're not engaged and they're not getting care, and their need for an engagement tool. Just to finish, I'll say that, you know, there's a lot of stuff here that is relevant at the state level in terms of statute. I have written a couple of op-eds. I don't know if you've read them, Gail. I don't know if you've read them. If you haven't, I do. I think they could be shared certainly with this crew who may have interest. But they really, I think, have helped articulate some of these principles and also gotten interest. Some of it negative, but some of it not. And what I'm saying is that there's a humanitarian crisis. And I'm saying that you can't engage in a paternalistic way unless you're guaranteeing attached resources, which is what activists and advocates say, and they're right. And that we have to go after it with resources first, up front. And the op-eds and this dialogue, which is going back and forth, is bringing a lot of legislative interest. So there are a number of legislators at the state who I believe are starting to listen to this narrative and this approach of kind of reframing engagement as a continuum, looking at grave disability and recognizing the importance of guaranteed resource, whether it's for relentless voluntary engagement or whether it's for conservatorship. So I believe that there will be efforts at the state level to modify LPS law, probably not to replace it. And I think it's important, but I think it's important that it's done in a way that understands the nuance, the complexity, and goes after the whole of engagement, piece by piece, as opposed to individual legislators throwing a new idea at a problem and frankly complicating the reality in the streets, which is a big risk. And the audit that was done, which was aimed at trying to do something similar to what I'm describing, didn't at all. It became, from my perspective, and I'm like kind of an anti-bureaucrat in a bureaucracy, was a bean counting exercise with recommendations, some of which were okay, but some of which were just not okay. And they missed really the big opportunity to say, hey, let's take a look at a state, at a system that is not functional. Part of the reason it's not functional is because the laws related to access and involuntary treatment must be re-engineered.
You want questions now?
Fire away.
If I can start, and there were a few things that you mentioned. The judges at the court. When Judge Donna Groman was there, she and I had a long conversation. What she wanted was these new judges that come on board should be educated. They should have a program for them to be educated so that they would have a better understanding of those with mental illness and not learn on the job, because in the beginning they're releasing too many people, and I think, Connie, you'll probably agree with that too, until they get a better handle of it, which is very unfortunate because it's so difficult to get to that point. So if there's some way that we can address the judges and request that they have a training, I'd be happy to write up something with Judge Gorman on that. For a training, if there's some way that maybe you can make a comment to Judge Harrison So we could do that. That would be a great thing. The other thing is the beds.
I'm sorry.
Go
real
ahead.
quick. Connie, obviously, as we're going through these things, we're probably going to get a number of recommendations. And I just want to, I'm asking you or someone from DMH that's on the call to help memorialize them. So
Yeah, I'm documenting.
I knew you were. I just.
You're so good. The other thing is, and I mentioned it to Connie earlier, the foundation, DMH can provide the foundation, and I know you're working to get more IMD beds, acute beds, et cetera, et cetera. But I think if we engage the community to sponsor extra items, I think exercise is such an important person. I hate to see somebody languish in a hospital bed waiting for an IMD bed because it's nothing but a holding cell. They're not doing anything for the person. But if we can get IMD beds and let the community sponsor exercise equipment, computer programs, education for applying for jobs, all that other sort of thing, things to stimulate their thinking, school, if anything. I think the community would be more inclined to step up and help those with serious mental illness, but through sponsorship. That would be another one. The other thing which really bothers me, early treatment. Everybody talks about early treatment. Research talks about early treatment. And we always guide ourselves towards those who are the sickest of the sick. And I know you helped me one time. We got a person on their first hospitalization treated with the LPS. And that person to this day is still doing exceptionally well. What I would like to do is see more LPSs done early, because the earlier we do it, we release a lot of the resources for repeated hospitalizations. You're utilizing so many beds because of that. The police coming out there, they're more compliant and more willing to accept their illness and come to terms with it and gain their life back. I mean, I'm not looking at stabilization. I am looking at total recovery where they can get their lives, they can get married. And I've seen it time and time again through our LPS program where people regain their life. And that's our goal, not stabilization or just being able to function, but to regain your life the way it was before you got sick. And I don't care how sick people have been or how old, when we get this, we can get them on the road to recovery. So I would rather see early treatment. If a person doesn't know that they're ill, to encourage the hospitals to do LPS. It's a lot less effort than going through this home team and this whole process, which takes months. And at that point, it's difficult. You mentioned rewriting LPS. I would rather see them term it supportive conservatorships. LPS has such a doggone negative connotation. It's pathetic. You just mentioned that to anybody on the street. Oh, how can you do that? I look at it, how can you not give them back their life? Because that's what you're doing. And another term, a supportive conservatorship. I think you'd have people more willing to do that. Anyway, those are my comments.
I'd like to.
You do an awesome job, and thank you, because I know it is unending and a fight constantly. But thank you so much for you and Connie. I can count on one hand the people that I know of that I know do a great job, and you are at the top of the list. So thank you.
That means a lot. I want to, and your points are all very important. As Connie knows, I mean, I don't like the term conservator at all. It's a big turnoff. And what I have suggested is that we use the term recovery facilitator, because really, I mean, that's what we want. What we want to say is that this person has to. We're left as a last resort to compelling treatment. But the reason we're compelling treatment is because we're investing in their recovery. And the goal is to actually not have someone conserved for life. There may be people who, for a variety of reasons, will never kind of recover the level of independence and agency that would be required to come off. But our goal has to be guaranteed resources, investing in someone as a person and their recovery. I really am in fierce agreement with you around early intervention. And I think that the concept of prevention, early intervention around MHSA has been so controversial because it's just been a grab bag of all these different things. And we have lost our compass in terms of the real core responsibility of the mental health departments, which is the most severe mentally ill, the most vulnerable people. And you're absolutely right. I mean, before I became a suit, I was a scientist and I was a neuroscientist, and I used to know a lot about the brain and about neural circuitry. And what happens when people have repeat and recurrent episodes, psychotic episodes and mood episodes, and more addiction, is that they consolidate circuitry, and that circuitry becomes more and more difficult to kind of let's just say redirect or rewire in a way that will allow somebody to function at the level that we would like. And one of the things that really bothers me is when you have hospitals or clinicians or counties, including our own, and it's like, that person, this person's really sick. A family member could say, we really think that would be great for them to get a conservatorship, and they're told, that can't happen until they have at least 10 hospitalizations in this period of time. I mean, that actually is kind of antithetical to the entire medical field. So what you're saying is right, but that becomes a part of the narrative. It becomes probably I'm sure that there are courtrooms where judges and where juries are saying, hasn't had enough hospitalizations for us to consider conservatorship. That's not at all progressive or informed thinking. But it is a part of the culture, and it needs to be dealt with. What I would suggest is that we think about leveraging the tools. I went over several tools, and if we can, for example, with advanced directives, with someone that has an early has a first break, as a part of that intervention, we can say, well, we're going to guarantee your resources, and we want you, now that you've gotten treatment, to help us understand what are the things that you're willing to accept. When you in the event that you have another episode, and when you have another episode, it's some level is the same. It's the same situation of being conserved, because we, as a mental health plan and through judicial authority, can say these are the things that you agreed to, and these are the things that we're going to apply, as opposed to not having that kind of authority. The last thing about community engagement and community involvement, I mean, I'm with you. I spent most of my career in the VA and at the West LA VA.